Hi. Um, so this is a video that I will start discussing, or we will start discussing actually, the social determinants of health. If you read the World Health Organization documents, you will have a clear idea with really detailed examples from all over the world. But I want to go through some of them, at least some of them, with you together. Um, and let's see. Um, so, according to World Health Organization, social determinants of health means the social conditions in which people are born, grow, live, work, and age. And these circumstances are shaped by the distribution of money, as income, as wealth, as property, or any other thing, power, as status, employment, gender, being male or female, or being homosexual or heterosexual, or other things, and resources. Resources can be both material, like income, or access to family networks that will take care of you if you are ill, kind of resources. Humans are also resources for you at global, national, and local levels. So, when we come to inequalities related to health, the document also says that these are avoidable inequalities in health between groups of people, within countries, and between countries. By avoidable, I made it red, we mean social, economic, political, and cultural elements that will be hindering you to have access to healthcare equally, or that may not prevent you from catching an illness, like environment, like your work, or other things. We can give a negative example actually. Like if you think of your someone that you don't know who has cancer, just like that, and we don't know the causes of it. I mean, it's very problematic to discuss even the causes of cancer, but we think that it is actually unavoidable. But when we think about it, if it is somewhere, like my grandfather actually, who died from stomach cancer, he grew up in the Black Sea region in Turkey, which is very close to Russia, which had the biggest nuclear disaster in Chernobyl that affected all their lives. And a lot of people at his age had similar kind of cancer in the region. So you can think even those kind of illnesses are avoidable. This is an example to think about layers of not only causes or results, but also possibilities of health inequalities. So these inequities or inequalities, you can use both language, arise from inequalities within and between societies. So within Turkish society, that part of the Black Sea region, part of Turkey, is particularly prone to having cancer because of Chernobyl nuclear disaster. So this is within society. But compared to UK, United Kingdom, which is far west of Turkey, Turkey is more prone to cancer due to nuclear radiation. So you can think of countries as a unit of analysis, but within countries there are different groups of people that are subjected to health inequalities in different ways. So thinking of layers and layers in terms of unit of analysis as well. By unit of analysis, I mean the the unit that we take for analysis. So when we look at the countries and compare the countries, the country is the unit of analysis. But when we look at the group of people within the country, a minority group, or women in a country, or African Americans in the United States, then this is actually a group of people within the society, or within the country. The group of people are the unit of analysis. So from all these examples, we can go back to the definition the World Health Organization gave. It says social and economic conditions and their effects on people's lives determine their risk of illness. As I was referring to Chernobyl nuclear disaster, the power plant radiation explosion in Russia, as an effect on people's lives in the Black Sea region in Turkey, and this determined the risk of cancer for some group of people living close to that space. Even proximity can be the reason of this kind of conditions, and the actions taken to prevent them becoming ill or treat illness when it occurs. So this is the other side of it. It is not the causes, but the results that are affected from access to healthcare. For example, if you go to certain neighborhoods in New York or in New Jersey, you will be able to find healthcare clinics very quickly at some places. At some places you can't find any. So this will be basically affecting all your healthcare accessibility. Or if you are under Medicaid and receiving only very limited kind of healthcare, then you cannot receive secondary or worse or third kind of healthcare, which is all about your class or income, or whichever you want to say. Okay. So let's come to the drivers of health inequalities. There are a lot of factors and institutions and organizations, as we will see in the other reading. But when we come to the general sense of drivers of health inequalities, we can talk about economic growth. In certain countries, economic growth can affect the poorest of the country as well. But in certain countries, there's such a high level of income inequality, like United States, like Mexico, like Turkey. The amount of wealth that is captured by 1% is at the top of the ladder, is too much, and the lowest 1% is literally, as they call, underclass, although it's a problematic term, but it is also, it means that there's a huge income inequality between the richest and the poorest, and in between there are a lot of varieties. So the economic growth that's affecting a country may not trickle down to the poorest. So this will make the poorest not having access to health care. This is also related to government priorities and policymakers' ideas or ideologies. If they think the poor is poor because of their own actions, and there is no structural actions, structural elements that's affecting the poor to stay poor or to become poorer, then you can easily say, let's not give any healthcare benefits to the poor because they just don't work. But if you believe in a more social or social democratic structural explanation, then you can think of all the reasons that's why this income gap is getting bigger and bigger. Are there any structural elements? Is this individual's fault, or is this actually a societal fault, or is this actually a discrimination by the government or by the market actors? Or there are many questions you can ask. Since we are sociologists, we keep asking these questions to those topics and to these people who are always talking about poverty and its relation to healthcare. And income is only one of them, as I said. And the trickle-down effect of economic growth may not be the case for many countries. There are also debt relations between countries. So a lot of developing or least developed countries are trying to pay their debts to their governments, try to pay their debts to the advanced nations, nation states actually, not nations. The debt relations are very important. If you have a very quick look, which we will discuss later, actually in very detailed format, that you can see that in global political economic order, there are a lot of financial institutions at the international global level, such as World Bank, such as International Monetary Fund, such as World Trade Organization, that regulates the economic order in almost across the world. And these institutions, as known as Washington Consensus, or after 1980s it became a global regime. You can see that powerful countries are becoming more powerful in these institutions, and the less powerful countries are becoming less and less powerful in this global economic game, in lobbying, in other activities. So a lot of underdeveloped and developing countries have to pay a lot of debt to these institutions, especially IMF, International Monetary Fund, who give loans to these countries with really high interest rates. If this sounds too abstract, then we can go back to actually your own education. Think about yourself getting loans from the United States government to have this degree as Rutgers, and think about the interest rate you should pay back to certain subcontractor company like Pearson or Sallie Mae or whatever you're paying for. So think about all these things happening at a country level and international level, with really big interest rates. This will make Kenya to stay poor or poorer even, because they have to pay the debt to IMF, International Monetary Fund. Another topic that drives these kind of health inequalities are gender biases. Gender biases in power, in resources, in entitlements, in norms, in values, can lead to poor health. For example, in certain regions, female doctors seem less credible to people, so this will reduce the access. Or in certain regions, the maternal health are not taken as a priority because it's a gendered issue, it's a female issue, it's not a male issue, and male issues should be prioritized under their patriarchal minds. Or even when you think of like a single mother taking her son or daughter to the healthcare facility, there are a lot of issues and prejudices among the healthcare service providers to you, to your child. It depends on your skin color, about race, also So gender can be very much intersectioned with race. So a lot of biases and discrimination, let's say. And also and other drivers of health inequalities, empowerment of people. By empowerment of people, it can be an individual, it can be a group activity, but it means claiming rights. So if we are empowered enough as citizens of the country or as human beings in anywhere in the world, we would like to have some rights, and we would like to have the capacity to be able to change or challenge certain unfair conditions, and this includes democratic participation into especially local municipalities, local governments, or national governments actually, that we can think that we can change things in healthcare and we can affect policymakers. So this empowerment is very important, and patients are citizens, or potential patients are citizens. So it is also between the citizens and the nation state, but also there are a lot of international human rights documents that will provide you enough legitimation to ask for public health and healthcare for yourself and your beloved ones. And governments and their priorities in policymaking and lawmaking are very important. And governments are not only elected members, also bureaucrats and then policymakers. They have to prioritize health for all. Otherwise, it is very difficult. If they prioritize rich over poor, or market over people, or other kind of or men over female women, or heterosexual rather than homosexual, then there are a lot of difficulties in changing or affecting healthcare policy. Also, economic actors and policies affect healthcare inequalities a lot, although it seems very indirect for most of us. Sometimes it is really, really direct, such as trade policies. Which medicine can be traded or not is a matter of health, actually. Or in agriculture, which kind of products are produced due to market actors, or which farmers are subsidized, by the government, or which kind of farmers are left to the market, can change the nutrition. And then infant mortality. By infant mortality, we mean the babies dying between 0 and 1 age old. So nutrition is a very important part of it, or employment, or education, and many others. What I work on is intellectual property and patents on medicine. So I can easily tell you, although it is a very, very convoluted process, the trade policy, which is regulated by World Trade Organization, the intellectual property regime, I mean, on medicine, is directly affecting the prices of medicine all over the world, and there are monopolies, which are pharmaceutical companies that are multinational, on prices. So if GlaxoSmithKline, for example, wants to put a price tag on a certain cancer medicine, you as the government or you as the people can't change it. And this will affect directly to all these cancer patients. So this is what I wanted to say very briefly about the drivers of healthcare. So now we can discuss, after the drivers of healthcare inequalities and health inequality, we can discuss what we want to imagine as a perspective of health or global health. First of all, as you can see very obviously from the book chapters that I assigned, that there's an emphasis of multidisciplinarity, the different scales of social, economic, political forces, from very large scale, like international institutions or global warming, to the local, which is your actual neighborhood, and from the social to the molecular, which we call biosocial approach. When it comes to biology, yes, of course it affects health. Of course, medicine has a chemistry, and of course our body is material. So there are a lot of virus, germs, a lot of illnesses that we don't know, the bacteria, a lot of like really biological elements that will affect our lives. But also, these elements can be very socially influenced. How we see health and inequalities and their intersections are very, very biosocial. It's not only biological, it's not only social, but biosocial. So if we very briefly look at the definition of global health in the Lancet. I don't know if you know Lancet or not, but Google it. It's an amazing medical journal, mostly published in the UK, and you can see many different articles, and we will read actually some of the Lancet articles as well in the course. So the global health is an attitude, they say. It's a way of looking at the world. It is about the universal nature of our human predicament. It is a statement about our commitment to health as a fundamental quality of liberty and equity. Or you can read it as equality. Actually, right now I want you to stop the recording and think if you agree, disagree, or just what you feel or think about these statements. Global health is an attitude. So when we think about Ebola crisis, we don't think about our attitudes that much. We think about the virus, how we can close the borders, how we can be cautious about such and such things, what are the diagnoses, what are the symptoms, and these are the things. But when you are a sociologist, you have to think about the social attitude. You have to think about the perceptions of people. You have to think about our human subjectivity in it. And liberty and equity are important for the Lancet publishers, but also for us. I want you to think about this question. What do you think of these statements about global health? This will also help you to come along in the blog, which is your weekly assignment. Since you stopped and come back, we should focus also on an aspect of practicality and the imagining, the vision. So if we accept a certain vision about health, and if we think that biosocial approach is the most accurate one to think about health issues, we should think about the plans, the reimagining, the remapping of health and its inequalities, but also its funding, its implementation, how policies are impactful or not, how policies are evaluated or not. So these are both practical elements with a lot of theoretical assumptions and reimaginings. So we should keep the bridge between them, according to Paul Farmer and many other people who work on health. Farmer obviously says that social theory is our toolkit. We need social theory to be able to talk about the consequences, intended and unintended consequences of social action and of inaction. So certain actors, sometimes individuals, sometimes institutions, sometimes global pharmaceutical companies, or sometimes global institutions like World Health Organization or something else, any actor sometimes act on things and it has intended and unintended consequences, but sometimes they just literally do nothing. So the intended and horrible drawer and unintended consequences are important for sociologists, but these are action, social action, and of inaction. So we should be very, very careful about these issues, intended, unintended, of social action and social inaction. If I have to give an example, I can give something like, if World Health Organization wants to have vaccination for measles all around the world, this is intended social action. If while World Health Organization doing this, the pharmaceutical companies do not give the vaccinations to World Health Organization for free or for cheaper prices, then this is an intended inaction. They don't give it. So this is intended because of profit maximization rather than giving the vaccine to the people. But also there are unintended consequences, and we will talk about it more, of course, afterwards. So the question that I want you to think more is, how can history and political economy help us understand the skewed distributions of wealth and illness around the globe? Think about the drivers of health inequalities that we talk about. The market actors, the governments, the policymakers, the local municipalities, anything that may have an impact on wealth and illness. And wealth, of course, is not the only variable that we should think about when it comes to illnesses and health issues, but it is also one of the most important ones. So now I want you to stop again and to think about the globe for a while, because we talk about health part a lot, but also the globe is a very big entity. And whenever we look at the world map, I feel freaked out, to be honest. So I want to make it a bit more fun for you, and I want you to have a look at it. There's a very nice world map game, and it has actually different types of quizzes in it. You don't have to do it, of course, but if you want to do it, there's a world map game. You can look at it and you can guess. Especially the Americas, I suggest you to do, because it is about different continents. When it comes to Africa, I'm horrible, for example. But when it comes to Europe, since I'm from this region, West Asia, Middle East, whatever you want to call, I can guess it easier. When it comes to Latin America, it's also difficult. But for example, for you, I guess Latin America and Americas in general are more easier to guess which part of the world. I think this is important to know where they are and how they are doing in terms of wealth and income, which the third quiz is about. You can learn a lot actually from this fun game. So you can link it, like you can click the link and you can see. So let's go back to our issues of global health again. So one other question. I'm guessing, hopefully, you'll read the first and second chapters of this book, Paul Farmer's book. And then, as you can very well understand, Mopazzo, I hope I pronounced it right, but if I don't, I'm sorry, is the start of the story. It says Mopazzo has been coughing for months. This is what I like about anthropologists. They can always relate to human beings from very start. So basically, he has tuberculosis and AIDS, and he's living in rural Malawi. There's a brief information about his life. So I want you to think, what are the forces that led Mopazzo fall ill with tuberculosis? Not only biological and genetic, but also socio-historical and political economic elements to think about. Also, why is a Patso able to attain good health care despite living in rural Malawi, while so many others in similar circumstances, or even in the United States, cannot? Sometimes the issue is not a matter of resources. Sometimes the issue is a matter of priorities. And we will go through all of those things. There are political priorities. Sometimes there are really population-related priorities. The governments favor one population over other. Sometimes other things. There are a lot of articles we will read about United States healthcare and Obama reform and etc. So you will understand what I mean by even in the United States. Other questions that we can think about are how does Mphatso understand health? Because it is not only a matter of socio-historical or political economic elements that's affecting Mphatso, it's also he himself, how he thinks about his own healthcare. In between these lines, there is Paul Farmer gives a citation from World Health Organization about how they define health. They say a state of physical, mental, and social well-being. You can say this is nice, this is precise, this is cool, but if you have any questions related to this definition, or any kind of criticism or challenge to this health definition, you are more than welcome. You can put under the comments on this video. Most of these issues regarding global health, Paul Farmer and their approach, biosocial approach, puts emphasis on structural violence. And by structural violence, as I'm repeating again and again, I hope I don't bore you, the structural violence is social, political, and economic forces that drive up the risk of ill health for some while sparing others. So this is basically, it is not only, this is very similar to the definition of social determinants of health and the social, political, economic forces, but structural violence is referring to drive up the risk of ill health for some while sparing others. And this actually refers to a lot of different inequalities all around the world. When I ask questions about Mphatso, one single case, I'm actually referring to a lot of different kinds of layers of inequalities. First of all, Mphatso is born in rural Malawi. It is rural, and it is in Malawi. So we should first look at the ladder of countries and their economic growth from 1 to I don't know, I think there are 216 countries in the world. So look at the countries and their income level, the GDP, the per capita, or purchasing power is maybe a better variable for people to be able to afford health care out of their pocket sometimes. Because in some countries the healthcare is private. Like in US, there is a little bit of private in it too. That's not in some social welfare countries. It's all public. You don't have to pay anything for any healthcare activities, like Sweden or Nordic democracies. Even in Turkey, it's 100% covered. There are also co-payments for medicine and some critical diseases that needs a lot of money. So Malawi is one aspect of it, but rural is another aspect of it, because rural versus urban neighborhoods can be different in terms of access to healthcare, access to clinics, mobility. I mean, I don't know if any of you lived in any rural part or village, but it can be very difficult to go to even give birth at a hospital in rural areas, in some of the rural areas. So this would definitely increase the infant mortality, because if you can't go to an actual clean hospital to give birth, then you as a mother can die, or if there's anything wrong with the labor, then your baby's in danger. Anyway, so these are all these different layers. This is only one rural Malawi, and you go into who is Mupatso and how does he think about health himself. So all the different layers, subjective and objective, can give us a lot of details about structures that the individuals live in and the structural violence that they confront with. As I was referring to gender bias before, think about all these discriminations, inequalities in the world, and how they can affect health. And there are some inequalities that are created from health and illnesses, because if you have AIDS, then there's a huge stigma. If you're in depression, then there's a huge stigma. So all these things that's affecting each other is very important. So for these layers and layers of layers to understand, we need actually theoretical toolkits to bridge theory and practice as big piles of things, to bridge this global hope that we could be part of the solution rather than the problem. But there are also practical implications of health. You need funding, you need institutions. These institutions are sometimes bureaucratized a lot. You need this time to process all these things, and you need a lot of empowered individuals to be able to change or challenge all these practical implications and practical solutions toward healthcare, or more equitable healthcare, as many international institutions refer. So health and illnesses are all biological, but they are also very much socially constructed. In the second chapter, there's a lot of theoretical toolkits that you should read really thoroughly if you haven't read it already. One thing that I told you that I was gonna go back to is unanticipated consequences of purposive action. And I want to give some examples about these unanticipated consequences, unintended or unanticipated. So one of those things is asymmetries, knowledge asymmetries especially. The relationship between doctors and patients can be very asymmetrical. What I mean is this. If I have no medical knowledge, and then if I have no interest in reading medical knowledge, and if I go to I'm a non-resident alien in US, so I'm originally from Istanbul. If I go to, I don't know, a gynecologist as a woman from Turkey, there are a lot of different implications there. One asymmetry is that the doctor can be very prejudiced about me, where I'm coming from. Many times, actually, many women from Middle East or from post-Soviet countries like Eastern Europe or Russia, in the United States, when we go to health clinics, there are a lot of prejudices that you should fight for. Not all the doctors, of course, but some of them can treat you as a really second-class human being, like ask you questions as if you don't know anything about yourself, such as we should do HIV/AIDS test for you first, and that wasn't the reason that I was going to a gynecologist. There was other issues, and the doctor insisted that I have to take HIV/AIDS test first. Because we are from somewhere else, or we don't have to go to even racism or racial prejudices or other things. You can only seem to have like equal relationship with doctor-patient. But still, doctors know that doctor has the authority of knowledge. He knows medical knowledge, of course, more than you, but you know your body more. So when you explain certain things, even language is a very important issue. If English is not your first language, then it's very difficult to explain what you have in terms of pain, suffering to the doctor. Or if you're very, very good, you have very good English, then you can tell whatever you want to tell, but the doctor can treat you as an ignorant person because he knows better in terms of medical knowledge, which is true. Sometimes doctors don't even tell what they think about your illness because they think they think you first. They have to be cautious as doctors because they don't want you to panic, but also because there are a lot of legal and social implications. Like the patient can go sue her if she's not right in one of the gases she did, or other things. So there are a lot of complex asymmetries between doctor and patient, which is the most embodied experience in health issues. The other thing is institutional values. Sometimes some institutions have some values that they think that it's moral thing to do, such as international development institutions who go to certain places in the developing world and building dams, changing infrastructure, giving a lot of aid to such and such regions, and etc. But then this has unintended consequences, like homelessness, displacement. If you give aid to one part of the population, the other part become poorer, and if you build a dam to make hydroelectricity central work on, then you actually disturb the nature a lot, and you don't know which impacts this can have. I'm not saying something pro or against, but I want you to think about the consequences that can have of these actions. And one of the most important things, very much related to these asymmetries and institutions, are power and authority. Power and authority questions that we have to think about. Knowledge is only one of them. Medical knowledge is one of them as well. Max Weber, if you take actually classical theory class, this is very useful right now. Max Weber talks about different kinds of authorities. There are three types for him. One is traditional, the other one is charismatic, and the third one is rational legal authority. And I would like to tell you that if you look at page 24, you can see actual table 2.1, that traditional authority is driving its power from history, custom, and habitualization over generations, accepted because it is how things have always been. So it's traditional, it's conservative, it's the status quo that has a lot of authority, and you may not even realize because it has been going on for so long. The charismatic authority is extraordinary leaders like Gandhi, like Malcolm X, like I don't know, there are a lot of powerful figures in the world that can mobilize people around an idea or a goal. And you can see, or Mother Teresa, you can see how these leaders can move people, like actual physically move, and see how this authority can give power to people. And the third one is rational legal authority, which is explained as consistent application of a set of rules and laws whose execution depends on a system of bureaucracy characterized by fixed and official jurisdictional areas governed by formal rules, a hierarchy of authority composed of a system of supervision and subordination, maintenance of files and records, official activity distinct from private life, separation of office and office holder, technically qualified personnel operating at full capacity, specialization of tasks and division of labor. So Weber explains it very well, but also he tells us that the rational legal authority can be very dangerous and an iron cage. It can turn into actually traditional, that has been habitualized, so that it cannot change. Also, there's a lot of power in making the rules and classifications and fixed and official jurisdictional areas by formal rules. These formal rules can be very dull and disenchanted, according to Weber. But they also make us rationalized and systematized. So all these kind of authorities you should be keeping in mind, and think about in healthcare area, what can those authorities imply? Are there any actors who have traditional charismatic or rational legal authority in healthcare? And if you write it under the video, I would be very happy to think about this as a comment. One thing that you can go from rational legal authority of Weberian thinking is actually Foucault. I hope some of you took contemporary theory and you know Foucault really well. In this chapter, there's a very limited understanding of Foucault and the very basics of Foucault, which is based on his ideas of discipline and biopower and a bit of governmentality. But you don't have to know all of those things, like in a very detailed format, but you have to know what biopower and discipline means related to the health. In figure point 2.3 on page 29, as you can as you can see here, and there's actually a conceptual kind of map, but not very small one, developed by Michel Foucault, to explain the power nodes and biopower and how it affects populations and individuals. So he basically argued, and actually, if you look at Foucault's work, you will see a lot of historical analysis of institutions. He goes to archives to understand the entire punishment system, especially the death penalty in France, so he can understand the origins of the issue, and they call it genealogy. You don't have to know it again. So in this one, in biopower, he looked at the mental clinics and a lot of other things, institutions related to health, to see the origins of these institutions. And he explains with biopower how biologic and medical data are used by the institutions of the modern world to define, count, and discipline populations. So we collect data about people, and World Health Organization is actually one of the biggest data source in this case. By collecting the information, we are becoming powerful, asymmetrically knowledgeable, and this biologic and medical data are used by the institutions of the modern world to define. We attribute certain categories and variables like infant mortality, like GDP per capita for healthcare, and things like this. And we count the populations, and we discipline the populations actually. So when the World Bank experts go to India and see all the statistics about India related to healthcare, they think they have enough information to implement or to suggest for implementation certain policies that are relevant to those statistics. Like, for example, infant mortality is too high, the babies are dying, and etc. in such and such region. And since they can define and count and classify the populations,
they think there are recipes to follow. And they sometimes solve the problems, but very, very likely to create more problems. So biopower is embedded in the processes of modern capitalism. It is very diffused, so it is not like only at one specific agent or one visible company or one government or something related to specific visible agents. It has visible agents sometimes. Biopower can show its face in different institutions, organizations, individuals, but it is diffuse. It is between doctor and patient. It's between me and you. It's between the knowledgeable and the less knowledgeable about medicine or healthcare. So it can the quantification of categories and the rules and norms and bookkeeping of healthcare can create unintended consequences of disciplining populations. Sometimes it is intended, actually. So there are a lot of examples in the book, so please visit them, like Bhopal, like Chernobyl, as I was referring to before, in the book. So knowledge became power, and knowledge power, with a dash, in Freudian terms, can discipline populations. And even talking about populations, not people or individuals or human beings, is one of the disciplinary power. Why? Because we call them populations and we think they are easy to fix, or we think they are easy to mobilize, or we think they are masses, uneducated masses that somebody can intervene immediately. But sometimes this has really, really, really horrible consequences. And this is actually disempowering many people. When you don't give any agency to those people who have been actually affected by certain elements, certain structural elements, and certain structural violence, as we saw before. So this is my last slide. I hope you enjoyed the first video lecture. You can listen to this whenever you want, and we will talk about the Globalization and Health Journal article in the next class, because I'm already out of time. Maybe it's 52 minutes, it's not 45, unfortunately. But anyway, it's fine. It's only 7 minutes more. I hope you enjoyed it. If it is too dense, you can re-listen it, you can stop it, replay it, and see if there's anything you didn't really understand or you didn't focus enough. I want you to take notes when you listen any videos, as I told before. So please try to take notes. This will help a lot to you to comprehend the content, but also to be able to do the assignments very easily. Take care. Hope you enjoyed it. If you have anything to ask, please email me.